Everyone. I'm Dzavik from Camp Hill, Pennsylvania, and it's my great privilege to host today's American Club Bifurcation Hour. We have a tremendous panel of experts here today, and I want to wish everyone a Happy New Year. First of all, I'm glad to see that the life is becoming somewhat improved in US. At least our COVID numbers have been going down. You know, our hospital COVID numbers are also improving. You know, we've been able to do more cases. So we have a short time today. We have a lot to cover. First, I'd like to introduce Dr. Rob, who is a current president of the American Bifurcation Club and also professor of medicine at Emory University. He really is very, very well known in the field of left main bifurcation. In fact, has written multiple papers about it. One paper which was just done as a position paper of American Bifurcation Club in a Heart International Journal just last month. He's also done a manual for STEMI for American Heart Association and many other publications related to bifurcation as well as imaging. So without further ado, I'll turn it over to Tanveer to show the first case. I think it's a very interesting case. I'm going to keep it very engaging. And then I'll introduce Kristen Brown, our fellow presenter today, and also Professor Dzavik from Canada a little bit later in the session.
Thank you, Raj. Without much delay, I really want to get started. It's a very interesting case of cardiac arrest with a STEMI and complex left main bifurcation and LFD stenosis. This is a patient 63 who at home had chest pain with palpitations. So the EMS arrived at 7:30 in the morning because she had an SVT going on, but you could also see clearly that she had anterior ST segment elevation, myocardial infarction. She received adenosine, and I don't know if that's the right thing to do or not, but versus cardioversion, but that's what the EMS gave her. And then she arrived, the ride, because of the COVID era, the ambulances are delayed. She arrived about, I guess, 50 minutes later. But when she arrived at the ER, she had VFib cardiac arrest, and she received defibrillation ×2. But she was comatose, did not wake up. EKU still consistent with the anterior STEMI. She did have ROSC in 5 minutes, but was comatose and intubated. And she was cool with ice packs. And you know, we just published yesterday the survival criteria for patients with cardiac arrest. And she clearly had a very short duration CPR. She was young. We didn't have measurements like lactate and pH, etc. But this was a VFib arrest, which is a pernicious cardioversion. So this is a good sign that patients will do well if they're resuscitated, and the arrest was brief. And so we decided then to take her to the cath lab. So here it is. Look at a ventriculogram. Very dysfunctional ventricle, large area of enteroapical akinesia. Initial EDP was 40 millimeters mercury. So from the time of onset of symptom at home, she hit the cath lab within 90 minutes. You know, so that's reasonably okay. But in the COVID era, got delayed. But this was her ventricular function. And this is her coronary anatomy. So you can see that the left main is almost subtotal. You really can't see much of the LAD. And there's a long stenosis in proximal circumflex. So I'll stop here and see if anyone has of the discussants, pretty Vlad, or Kristen or Raj, have any questions.
So Tanveer, you know, a couple of, you know, interesting rapid fire questions, I think, for the audience. You know, so cardiac arrest, you know, with the STEMI versus non-STEMI, and clearly there is a difference in current thinking about whether the patient should rush to the cath lab or not rush to the cath lab. So this is a clear-cut EKG showing ST elevation. So I would say there will be pretty fairly a good consensus that this is a good case for emergency coronary angiography and treatment. Now, you know, what we would do in our lab in a situation like this, you know, would be to do a femoral angiogram first. Would you have considered, even before looking at the coronary, to say, as soon as we did the LV-gram, that let's put her on a hemodynamic support?
So yeah, so what I do, in practice, what I do is, in these kind of cases, I go femoral, I don't go radial, particularly in shock. So we did put a 6 French sheath in, and I used multi-purpose catheter. That's what I did the EDP and the V-gram with. MP is an Emery thing. This is one cornea picture that you see. And this is the right, was not very easy to engage, but right was patent. And I did not pursue trying to really engage it because the patient had hemodynamic collapse from the left circulation.
And it's
So-
open. It's
So,
open.
and it's open. So what we did next was we did do a femoral angiogram initially, Raj. This is the picture actually that I took before I did the coronary. So this is the angiogram, but I wasn't sure what was up there, a little higher up. So when I came back to do the pre-closes on this, I used a pigtail to do that, and this is pretty good size to take an impella in. That was the plan. We pre-closed this at 11 o'clock and 1 o'clock, and then we put an impella CP in. So the issue is that, when you put hemodynamic support, clearly the patient has a left main, she's in shock, okay? And I think the current registry information is put support in before you do anything. So I'll open it up for discussion between Vlad and you and Kristen as to whether this is the
So
right.
Vlad, I like to ask you a question, just to, we have several participants, in the audience today that are OUS. So we know that outside of United States, the availability of the impella is somewhat limited. Would you have considered doing a intra-aortic balloon pump, or you would say, okay, let's just see if you are an ECMO center and you do this all the time, that this would be a great case for a immediate ECMO insertion such as CardioHealth?
Yeah, I'm one of your OUS participants, by the way, but Tanveer, remind me, what was the pressure and what were the meds?
So the patient was on a little bit of epi and levo, but the EDP was 40, okay? And the systolic pressure was around 80 or so.
Yeah, I think, you talk about registry data. We don't have good randomized trial data, right? So we have information that unfortunately is not perfect. And even if you look at the registry data, the bulk of it from, I would say, population-based or large registries in the US actually do not support the use of impella. I have to be honest in saying that. It's only small registries that are, that are very focused on the impella that suggest that there may be a benefit. So I think, on the other hand, you ask about the balloon pump. We have one randomized trial with the balloon pump, and it's a good group. It's a good trial. The Shock IBP2 trial of Holger Thiele, 600 patients, which showed no benefit of balloon pump versus, or how should one say this, of routine balloon pump versus only bailout balloon pump, right? And there were a certain number of bailout balloon pumps in that trial. That is a very unusual trial, I have to say, because the systolic pressures were very high, and the mean ejection fraction in that trial was 35% higher than any other shock trial that I'm familiar with. So, and they put in the balloon pump after the PCI in 84% of cases, as opposed to before the PCI. So you ask me about this patient. Yes, I think that mechanical support in somebody with a systolic pressure in the 80s, who's already on epi and norepi, is reasonable. That patient actually, by the way, does need some inotrope with vasodilator action with an EDP of 40, but you can probably only achieve that if you have mechanical support in this particular patient. If you have an impella CP, great, but I would not discourage you not to use a balloon pump if that's what you have. I'm sure in many places in America, people have a balloon pump as opposed to an impella as well.
Yeah, I think that in our lab, we would 100% do exactly what Tanveer has done. I think that, I strongly believe that a case like this, it's really an ideal case for hemodynamic support. I know that the data is somewhat conflicting because it's very difficult to put a homogeneous shock population in any of these studies. But if I didn't have the Impella, I'd have zero hesitation in putting the balloon pump in. And then, I would have no hesitation in escalating to, something else if necessary. The one other question that I did have, Tanveer, that, in the emergency room, did she got a ticagrelor oral dose, or, she was out before any of that stuff can be done?
So, we did have we did give the ticagrelor probably at the end of the procedure by an NG tube. We did that.
I see. Yeah. So would you have done cangrelor or intagrelin or agrostat?
We don't have cangrelor available, but I'll tell you, I'll come to that in just a minute. But one other thing, I did a single access technique to put the Impella in, and also through the to the Impella sheet, punctured it at the side to put my sheet in, to put it in my guiding catheter. 6 French sheet. This all is 6 French. This is 6 French guide. So let me keep, in the interest of time, let me keep going.
So I've actually done 8 French access through a single access as well. It's possible to do 8 French.
So basically, both vessels affected. You put both wires down, and then so this is a long lesion. And one of the things that concerns me when you see a long lesion like this, could this patient have had SCAD? What do you guys think?
Yeah, my personal opinion is that this patient has a plaque rupture. There's a massive amount of distal thromboembolization. I think that what's really important in this case is the circ and the left main. The anterior wall is really, akinetic, and we'll be able to achieve something there, but I don't think that we're going to be able to achieve a lot, in my opinion. This is a kind of case, we would have, in the era of infused AMI, this was a few years back, with a STEMI trial, we would have considered you doing intracoronary FSCAI in a case like that. That would have been very, very helpful. But neither the clearway catheter is available now, and FSCAI is pretty much disappeared from the market. So I would say cangrelor and do some form of I personally would say that we would probably inject some vasodilator, micro vasodilator therapy in the distal apical LAD with some kind of a micro catheter to improve the myocardial perfusion and reduce the edema, and then do some thrombectomy and open both arteries.
So basically, I did it with a daughter with a 2.0 balloon. Go ahead.
So you have not ballooned yet distally.
I just daughtered this initial pass. Then I did serial balloon inflations, distal to proximal, including the left main, distal to proximal, and then also you see the prox LAD and the left main, and then I did an IVUS, and IVUS showed there was no SCAD. I'll show you the IVUS right now. This is the IVUS run. Distally the vessel is okay, but as it comes back, you see that the LAD is full of atheroma. You can start that in mid portion, see the plaque in the LAD coming back all the way. So this is all atherosclerosis, the long lesion. It's all atherosclerosis, and you will see a big plaque burden at the prox LAD as it comes more proximal, and also in the left main. So,
but it's not a huge vessel, is it?
No. So it's coming proximal. See the plaque burden there, and we're going to come
bifurcation.
Yes, it's a heterogeneous plaque, and we should be coming up towards a circ pretty soon, into the left main. A lot of plaque there. And this circ coming in the view, and no, that's a diagonal probably, and the circ will come up pretty soon. And to the left main is pretty stenosis. That went very fast, but the left main had critical stenosis also. So it's all atheroma, and the area in the left main, the MLA was 2.8. So what we did, this is post balloon inflations after giving intracoronary nitro. This is what it looks like. So we stented distal to proximal, 2538 distally, 2538 mid portion overlap, mid to proximal. This is distal, and then mid to proximal, but the LED ostium was not covered. And then I did a DK crush technique with a 3/5/18 DS in the left circ with minimal protrusion in the left main. And then did a balloon crush with 375/12 non-compliant balloon. Then did a proximal rewiring with the first kissing balloon inflation. Then I put a 3/5/22 DS left main to LED with overlapping the LED in the prox LED, but not at the bifurcation. You try not to land at the bifurcation, then you'd have many different layers, but you just extend it to where the LED stent ended. So you put the stent back to the left main. After you take the equipment out of the circ, you do a pot with a 375 NC balloon, second rewiring, and second kissing balloon inflation, and we did a final pot with a 40 NC balloon as part of DK crush. So this is what it looks like, the post-IVUS run. Distal to proximal, stent is well expanded, well opposed. And into the left main and out. And the MLA we got was 9.9. Always IVUS the left main and a DK in a standing procedure. So this is what the vessel looks like in two different views. There's a step up here in the mid circ, and this is what it looks like in the cranial view. So the final left main MSA was 12.6, and the LED MSA was 6.6. And this is the result of the intervention. So I'm going to stop for any questions you might have.
Yes, so a couple of questions from the audience, and we have only 5 minutes or so for this case, so we'll go through them pretty quickly. But first question from Dr. Lavara was, in an unstable patient like this, is ventriculography required?
We are big believers, yes, we want to know what the LV function is. You know, if you're checking the pressure, and I think it's always a good teaching to know what your ventricular function is very quickly. I don't think there's a downside to it, you know.
Yeah, and I think sometimes you have VSD.
Yeah, that's right.
Exactly it. It's also very useful to understand that there are no mechanical
complications like as VSD.
Right? Yeah.
We always do ventriculography in our lab as well.
This is a hand
question from the
it's not power injection, it's a hand lever. So.
Yeah. Second question from the audience is, would you have considered use tirofiban in this case?
So we gave a bolus dose of tirofiban, but not in infusion. And I don't like putting them in infusion. If in impeller there, you have a lot of groin bleeding issues.
Yeah. The third question was impeller left in?
Yes, so the impeller was left in, so I'm going to go very quickly. You always should do a right heart cath, but look at this, RA mean was 4, RA strike 35, PA 20, wedge mean was 6. So something's going on. This person is shocked. Why are these numbers low? So the patient is having oozing around the big sheath. So what happened was we had removed the 14 French impeller peel-away sheath, and repositioning sheath was advanced sutured, but there's significant groin oozing. And you see the HNS drop from 1344 to 1031. Groin was redressed. Now, where I performed this procedure, we don't have a shock unit. We have made one of our 7 hospitals a shock care center. So we decided to send her away immediately to our shock care, where our heart failure doctors take care of these patients. But when she arrived there, her pressure was 54 or 43 with a heart rate of 140, and she had bled down to 5.7 grams in the ambulance ride. So she was given 4 units of blood. She was continuously bleeding from the impeller site. Protamine was given, and the impeller was removed, and there was no retroperitoneal bleed. But and this was you can see the impeller is partly back in the aorta. The ventricle is very dysfunctional, but at 48 hours, you can see there's been recovery of ventricular function. And but unfortunately, central lines are placed in her, and she started swelling up in her upper extremity in the face. And in her course showed that she had SVC syndrome with a large mediastinal mass. And she was actually biopsied while on aspirin ticagrelor and had non-small cell lung cancer. We were unable to wean her off from mechanical ventilation, but eventually she survived 30 days. She couldn't, the radiation did not shrink the size of this tumor, and she was not a candidate for chemotherapy. She was discharged from hospice and died 30 days later. One other final point I want to tell you, those who want to leave this in, one thing I learned from that is don't suture on the sides, suture from above down so that you sort of pull back on the impeller sheath, because if you leave it flat, that's when it oozes the most. So the impeller sheath should always be in an angle with the suture from the top down to pull it upwards, and have a little wedge of gauze under that so that it maintains position. But this position, apparently, they just bleed a lot. So I'm going to stop here. I've done my 20 minutes, and I'm going to stop this case.
No, I think this is great. I think that I'll summarize it. You know, it's a great case for acute coronary syndrome, cardiogenic shock, very timely intervention in terms of getting the hemodynamic support in. As everybody noticed, that the impeller was put in first before interventional procedure started, which I think is very, very critical. You know, I think that we obviously have to be very concerned about the groin site with the impeller device. You know, we've been lucky here. We do have our share of groin bleedings as well, but you know, sometimes it can be a problem. We do sometimes use endovascular techniques to stop that type of bleeding if there is that much bleeding. The technique which was utilized for bifurcation was perfect, you know, because the bifurcation angle was over 70%. So I think that this is a kind of case where DK crush, mini crush, tap type of techniques work very well. You know, it's unfortunate that she had cancer, but otherwise she got a really world-class treatment. So thanks so much, Tanveer, for a wonderful case. Let's keep moving. It's a pleasure to welcome and introduce Kristen Brown, who is a cardiology fellow at University of Nebraska Medical Center. She really has a phenomenal case. She's a very, very bright fellow. I had an opportunity to talk to her just a few minutes ago. She aspired to do this as an intervention, and I have no doubt that one of these days she'll be on the big screen. So it's up to Kristen now.
Thank you so much. That was a kind introduction. So we'll go ahead and get started. I also did this case with Dr. Andy Goldswig, so I don't want to not give him some credit, but he's not here with us today. But I'll go ahead and get started with our case presentation. To start off talking about our patient, I have a 51-year-old male. He had a history of a recent STEMI and resulted in a drug-eluting stent placed to his left anterior descending artery, which subsequently resulted in a stent thrombosis and wound up at an outside hospital, got a second layer stent, so now 2 layers of stent, and which resulted in jailing his first diagonal branch at a close outside hospital, resulted in persistent ST elevations and persistent refractory angina. So he got sent to us for further
what is the time course from the stenting of for STEMI to when the patient arrived to you?
Yes, so the first one, the first STEMI was a year ago, and then the second was like a week ago.
So Kristen, this diagonal was jailed by 2 stent layers, correct? It was in a segment where there were 2 layers. Okay.
There were 2 layers of stents, and that resulted in jailing this diagonal. Yep. So this is our EKG when he got to our facility. There were multiple at the outside facility where he persistently had ST elevations and the constant chest pain. When he got to us, he was normotensive but lower blood pressures. And the main thing that stood out on his physical exam is she was just complaining of severe chest pain, Levine sign. Troponin was rising. It was elevated at the outside hospital and elevated at our hospital as well. So just going through his angiograms here, I think it'll play, and then I'll go back through them just to kind of highlight a few things. So kind of going at this, our spider view or iliocaudal, I just wanted to point out here that you can see that there's some disease in his left main. Here, right about distal left main, and then going to his iliocranial, you can see that's the diag that was jailed. It is getting a little bit of TIMI flow, but it's kind of blocked off there. So that was kind of our culprit. So when he initially got there, our goal was to potentially open up that diag. Multiple attempts were using different wires were attempted to actually access that diagonal, but given those double stenting, none of our wires were able to access. So we used a whisper wire run through hypercoat and a pilot 50 with no access to that. Then we proceeded to balloon that stenting area just to potentially open up the struts or where the stents were to potentially be able to rewire. So we tried to rewire after we ballooned it with no success. So at this time, patient wasn't doing well, had a lot of contrast given, and he was kind of teetering on cardiogenic shock. We actually ended up placing an Impella, and the decision was made to like send him back to the floor and then come back at a later time once he was a little bit more eubulemic and not as shocky to proceed and maybe look at that left main as well. So that's what he did. This is him coming back to our cath lab. We first focused on that left main, given it had that distal possible little bit of stenosis. So we did IVUS on the left main, and his IVUS left main had a minimal luminal area of 6.4. So hopefully y'all can see that there. And then we'll go to the next slide. So after a different technique, we went with our twin pass catheter just to see if we can kind of guide our wire to and through those struts a little bit easier instead of fiddling around with trying to engage with just our free wire. So we were able to engage with the twin pass. It just allowed us to get through a little bit better, and that might have been the time as well that potentially facilitated our engagement of that artery as well, using the run through hypercoat. So it actually went in pretty easily without any struggle. So just to go over the twin pass, there are two types. The one that we have in our lab is the 5200. There is a torque twin pass as well. There is a difference between the two. You can see the ends are one's short and one's long. And then there's also the key thing that probably will affect our use of this catheter is there's a difference in deflection angle here. On the torque, there's about a 10% deflection angle, and there's actually 0% in the non-torque, which again is the one that we have in our lab.
Can you explain it, this deflection angle? The tip does not move, right? So it's
no, the tip doesn't move, but it's reported that right here, when it comes off, it will deflect your wire about 10%. Okay. 10 degrees, sorry. Yes, 10 degrees. And the other one won't deflect it at all. So that might play a difference in which one you want to select if you're dealing with a difficult angle. So I'm just gonna, so after that, we decided to place a stent balloon and then stent our lesion. We used a 2.5 by 15 millimeter non-compliant balloon to pre-dilate, and then we deployed a 2.5 by 16 millimeter synergy drug-eluting stent to the diagonal.
Can I interrupt you here? So
yeah, absolutely.
The stents, was it difficult to push a non-compliant balloon through?
We had a little bit of difficulty initially, but we were able to pass it it was in the first pass. So.
And this diagonal closed because it was jailed, right? So,
right.
So if you just balloon it open, why do you think you needed to put a stent through this, or two little stents that are already there?
Right. Yeah, and that's a good question, probably a little bit over my level, but I think the thought process was that we wanted to maintain its patency at that time. But if some
Maybe,
of our
maybe
other
I can answer for Kristen that question. You know, my view would be, you know, that if this patient becomes so symptomatic from, you know, this diagonal occluded, even with the TIMI2 flow, that, you know, I'm sure with balloon it might look well, but it's going to restenosis, you know, after balloon H plus in a few months, and perhaps putting in a stent in may prevent that restenosis, and that would be the thought about putting the stent in. Given that, you know, it's impressive, you know, how much symptoms the patient has from a diagonal subtotal occlusion. Yeah.
Do you have a pre-stent view, pre-stent cine?
Yeah, she showed that earlier.
Yeah, I can go back if you would like.
Both balloon, but pre-stent. Yeah, this one.
This one, yes.
Not a good flow.
Yeah.
Yeah, I'd have to agree with this kind of flow.
Oh, sorry.
I would certainly stent that.
Yeah. So the criteria is TIMI flow less than 3, basically.
Yeah.
So that's reasonable.
All right, so going forward, what we did was we used a 2.75 by 15 millimeter non-compliant balloon, and then we crushed the diagonal stent within the LAD over the per water, and then we rewired with the run-through hypercoat. And then after that, we did a kissing balloon technique. We used 2.75 by 15 millimeter in the LAD, and then a 2.5 by 15 in the diagonal here. See that? And then we did a proximal optimization technique using a 3.5 by 8 non-compliant balloon. So we did, and using stent boost, which is common in our lab to use stent boost just to optimize our location of where we're placing our balloons and stents. So just in conclusion, this is our final angiogram after all was said and done. So we had good flow down our diagonal, and our patient actually resolved symptoms almost immediately inside the lab, which was nice because he was in a lot of pain during the procedure and prior to the procedure. So that was nice to see. After the case, he did well without any complications, remained angina-free, and was discharged home. So it was a successful case. So
I guess the question would be, why would the patient be so symptomatic with a side branch occlusion at diagonal, right? And almost shocky, as you said.
Right.
That pertains to the length of the diagonal, and CT angio correlate studies have shown that a diagonal that's 73 millimeters in length, or a side branch, correlates with an LV of 10% of myocardial mass. So that's why this is a huge diagonal in terms of how much territory it actually covers. It's really the only diagonal that's there, right? So
right.
So Vlad, you know, a couple quick, you know, rapid fire questions. You know, what are the techniques of rewiring an occluded side branch after main branch stent? You know, based on EBC techniques that, you know, we repeatedly talk about at the C3 meeting. Can you, for our audience, describe 3 important ones that you most commonly use?
Of rewiring?
Yeah. You know, when the branch is occluded like that.
Yeah, so first of all, it's always nice to have a wire in the branch, but we don't always, and I show a case as
so
well.
Prevention is very important, and that's by leaving the wire in. Yeah.
Exactly. But this was not the case. That was already, so obviously the twin pass is a good one. An angled microcatheter, such as we use in the next case. Those are some of the techniques. Obviously, some of your more weighted wires would also be helpful. Wires that have lubricious coatings or slippery wires would also be helpful in that situation. In terms of rewiring, And then, of course, microcatheter is very important, either an angled one like was used here, because bare wiring is always fraught with problems. So those are some of the things that I tend to use, and maybe you have some others for me.
And one technique that maybe I pass on is that when I have 2 layers of stents, typically we would always think that using a slippery wire such as a Whisper or Pilot 50 should be very useful. Yeah. But when you have 2 layers of stent, you need some force for that penetration.
Correct.
And I would, in a situation like that, I prefer either a Miracle Bro 3 or a Gaia 1 type of wire.
Or even a Miracle 6 maybe sometimes.
Yeah. So I think that's an important thing to remember. The other technique that that's been shown before is that in an extreme situation, you can try to wire behind the LED stent to get into the side branch and put in a short balloon. However, if you don't have an existing wire there, it is very, very tough to do. I have not had success every time, except maybe once or twice. Yeah,
I think that would be probably risky, especially with 2 layers already.
Yeah.
Yeah, that would be challenging.
Yeah, but that's another potential option. And doing a pot is a great thought, which was done in this case, which I think is a really, really great idea to try to open the stent strut layers, and then
the pot not only opens up the cells better, but it also, if you do the pot in the right position so that the shoulder of the balloon is actually right at the side branch, you actually change the angle of entry into the side branch, and that alone may make it easier to actually rewire after that. So a very, very good thing that was done.
The venture catheter is also back.
The
modified version, you can use that. And some people use a Pilot 200 even for penetration.
Force, a little bit of a force. Okay, those are all great suggestions, Kristen. Great case. Thank you very much for bringing this case to us. Let's continue. It's now my privilege to have Dr. Vladimir Dzavik, who's a very well-known bifurcation specialist. He's professor of medicine at the University of Toronto. He's a part of the American Bifurcation Club founding members, as well as part of the scientific advisory board of C3 Congress. So he's going to do the lecture about optimal side branch treatment with reverse crush. So I'll turn it over to you, Vlad, now.
Thank you very much, Raj. It's a pleasure, as always, and great cases, great discussions. So let me just share I think it's the desktop I want to share. And next, how's that?
Good.
Looks great.
Excellent. Okay, good. So this was I thought that was interesting because I really like Kristen's case, and I thought it was well presented. I thought it brought some really good concepts to the meeting. And I had a very similar case recently, not with 2 stent layers, mind you, just 1, and completely self-induced problem. But, we all have those. So, so this was let me just, excellent. Okay. So this was a 79-year-old lady who presented with a several-month history of exertional chest tightness, dyspnea. She was in optimal medical therapy, had by echo an ejection fraction of at least 65%, who a few weeks prior to me seeing her in the cath lab had undergone a diagnostic angiogram, which showed a very small non-dominant RCA. There were some collaterals to the LAD from an RV branch, but they certainly were not interventional collaterals. And her left coronary artery was as follows. If I can, oh, there we go. Okay. So as you can see, she has an occluded LAD with a nice cul-de-sac, nice stump there, and this dominant circumflex. And we brought her on this occasion to do the CTO, but realized that this circumflex is probably significant and that we should probably take that off the table before we, with it being a dominant vessel, especially before doing her CTO. And so we further evaluated this and confirmed with this IVUS that indeed that proximal circumflex was a very significant lesion. So we proceeded to
My question
wire.
for you, Vlad, if this is a left dominant system with the only remaining vessel, would you not want to fix the LED and get that out of the way before you fix the circ?
Well, I think our feeling was that this was a fairly straightforward lesion in the circ, and it was tight, and it's her only remaining vessel. You're absolutely right. So I'm not sure that doing a complex procedure with a significant tight circ of a CTO, which can be a 2-3 hour procedure, in the setting of a tight proximal circumflex that looks fairly straightforward to open and stent, that we didn't feel that was the best approach. So that was our.
I would have to agree. I would fix the circ first before I do anything with this LED.
Would you think of support with the last remaining vessel?
Not with this. I mean, it's almost a type A lesion, so I would not have thought about support. We did have, so we thought about radial, transradial, which I do in 80% at least of my cases, but she had a very poor radial artery on both sides. And so we elected to go transfemoral, but we did have, in fact, two. We had a sheath in the right femoral and a sheath in the left femoral. So we could quickly put in support, deploy support if need be. And that's always important, I think, from my perspective. Her LV function was excellent. Had her LV function been poor, I might have thought about it differently. So 3x15 balloon. This is the result after the balloon. Looks good. And so we deployed a stent. This was a 3.5x20 Promus Premier stent. And then we, based on the IVUS that we had done, we knew that this was a 4mm vessel. So we post-dilated with a 4x15 balloon. And at this point, she started to complain of quite significant chest pain. And yet the circumflex looked very good. However, I'm sure you know
OM's gone. Yeah.
The OM is gone, right? The OM is gone. And as we looked at this, we thought, how stupid of us. It had a tight osteal lesion. It really should have been wired at the very least, if not treated at the same time. But that's all. The retrospectoscope is a very useful tool. It's a good tool, but it's not very useful, I should say. Okay. So
I've done it many times, so don't feel bad.
Yeah. So here we are, and we really can't see where this thing takes off. It was very much a guessing game. Probably took us an hour to actually get into this. So Turnpike microcatheter, Xi'an blue, Xi'an black, and IVUS. The IVUS actually showed us exactly where this was. And so then we did some more efforts. As you can see here, this is part of our ongoing effort. There's the microcatheter there. There's the, I believe, one of the Xi'ans that we're using. And then finally, so we upsized to an 8 French. We utilized the Supercross 90 microcatheter. The Supercross is a very low profile microcatheter, but the Supercross 90 also has a 90-degree bend at the tip. So with that, we were actually able to manipulate and maneuver the 90 until we got the Fielder XT into what looked like here, the side branch, right? And then we post-dilated, or we actually brought the microcatheter right into the side branch and exchanged this out to wiggle wire.
Could tell you why do you change a wiggle wire? We already had a wire down there.
It gives you support.
Okay.
it gives you very good support and lets you own the vessel, the side branch, basically. It's unlikely to come out as easily as a fielder would be or most other wires.
And it's also going to cause less wire bias in this very upgoing OM branch through the stent, so that it will easily. I think it's going to make the delivery of the balloon somewhat easier. Now I don't use very many wiggle wires. So I probably would have done it just with the regular wire here, and I think that would have been okay too. But wiggle wire is not a bad thing.
So we actually had to use the 1.5 balloon to get through these struts, 1.5, then 2.5. Here you see the angiogram after the 2.5 balloon. And I'm trying to use as little dye as possible here. But you can see that the vessel is open. And so then we decided to go with a reverse crush. This is a very low angle bifurcation. It's not great for a T-stent. It's, in my mind anyway, a tap is not a great procedure here because you end up with a lot of stent in the main vessel. And whereas I don't use a reverse crush a lot, I think it's a very good technique for this kind of a situation. So we deployed a 2.5 by 23 Zion Sierra. And then here you can see a crush balloon. So I do the crush a little bit differently. I actually size the crush balloon for the proximal vessel. And here there's not much difference between the proximal and the distal vessel. But I essentially do a pot crush in my DK crush techniques. And I use that same pot crush technique for this. Why do I do pot crush? The pot crush actually, in the same way, you need to do a pot crush in order to fully crush the crushed stent. Otherwise, if you only crush it with a stent that's sized for the distal vessel, you end up with an incompletely crushed stent. And hence you have the possibility, strong possibility, of actually going through the lumen as opposed to of the main stent, as opposed to through the two stent layers that you're supposed to do in the crushed stent. So here we see the positioning of the balloon. Just
is that a 4.0 by 8?
This is a 4.0 by 8.
Okay.
Just distal to the carina with a low pressure inflation. So here we are. So there it is, just distal to the carina, low pressure inflation to ensure that it's completely crushed distally. And then, so there's the first one. And now a more proximal one with the distal balloon marker being at the bifurcation so that the tip, if you wish, is right at the carina, which changes the angle, again, optimizes the angle of re-entry for you and into the side branch, and opens, as was demonstrated and stated by Kristen as well, opens up the struts better. So it's, and crushes the stent completely, being the same size as the proximal vessel. Okay, so that's really important. So this was our result post-crush. Here we're recrossing with the workhorse wire. And where do you recross? You don't recross, because this is like doing the first step of a DK crush. So you don't recross distally, because if you recross distally, you could actually go abluminal on the distal edge of the stent and then re-enter. And when you balloon that, you could actually completely deflect stent material from the distal edge of the ostium of the side branch. So it's important to go proximal to mid. My view is that it should be more mid. Otherwise, if you're too proximal, then you develop too much of a bulky neocarina. So I like to go mid, and this, in my mind, was pretty mid. Again, post-dilating with 1.515 balloon, and then 2.7515 NC in the OM through the struts, 4x15 NC in the main vessel, the circumflex, and then a very low inflation, low pressure kiss with both of these. And that's simply to redirect to direct appropriately your neocarina and to ensure that you have no deformation of the main vessel. So this was our.
Did you come back with a final pot or not?
I did not. I did not, and the reason I didn't, because I had already done a pod, Tanveer,
Okay.
and
Sure.
because my KISS is very low inflation. The whole rationale behind, especially the EBC recommending a pod at the end, is that they tend to, or at least tended to, do the KISS at high pressures, and so that will ensure that you have an elliptical vessel proximal to the bifurcation. Whereas if you go low pressure, that's not going to happen, and I think you'll see that probably didn't happen.
This is a very large vessel, and now that you've plumped it up, it supplies collaterals to the LED, so it really covers a large territory.
Yeah, absolutely.
So Vlad, there's one question asked,
Yeah.
and this is the right time to ask it. People want to know, how did you use your IVUS to find the opening into that marginal?
Well, we saw where the side branch took off through the
Do you
stud.
use an eagle eye, or do you use a Boston, or what do you use?
It was a Boston. It was a Boston that we had.
And then you mark it, or do you leave the IVUS there because the large vessel that you wire, or do you mark it in some way?
We marked it. Yeah. Yeah. So here you can see the finals IVUS. Since we had the IVUS, there is this is going through the side branch into the main vessel. So here's the stented, nicely opposed stent in the side branch, the OM. And now we're coming to the carina. There's the carina. There you can see an absolutely nice result with no struts hanging into the lumen of the main vessel or in the side branch for that matter. And a very nicely circular result proximally without the final pod, because we had already done a pod, if you recall. So 7 weeks later, we brought her back for the CTO, and I'll just show this very quickly because this is not a CTO session, but there is a reason why I'm showing this one. So we got a Xi'an blue into what clearly was a septal, so we pre-dilated this with the 1.5 and then took a picture and then surfed. That was obviously septal. And then we took an angiogram and used the angiogram to further advance the wire through what looked like the true lumen of the vessel. To make the long story short, after this was the final result. And so, and you can see the nice ongoing result in the OM and the circumflex. And what we did was at the end of this, we did an OCT in the main vessel, the circ. And I'm just going to do this manually. We had used not that much dye, but nonetheless, I have to tell you that this was done with saline injection, not with contrast. So there are some situations where you can actually get a pretty decent OCT result with saline, especially if it's proximal. So here we are going through the mid-circ and coming up to the side branch. Here's the side branch coming in. As you can see, no struts in the lumen anywhere. A very nice looking carina. And finally into the proximal vessel. A very good spherical result, I would say, or a circular result in the proximal vessel. So that's what I wanted to show. I think this is a reasonable technique in appropriate cases of low angle bifurcations with significant side branches. This one obviously was significant. This patient was having a lateral STEMI with this, and done well. This is probably the best result you're going to have with any other technique, is my view. So thank you.
So thank you, Vlad. One of the questions come up is from Dr. Ludwig. CTO, do the CTO first because you're placing your left circ at risk for subacute thrombosis. How would you answer that?
Well, I think we already discussed that. In this case, good left ventricular function, a fairly straightforward lesion, and only remaining vessel. Am I going to leave that as a tight lesion before embarking on a complex CTO? My view, and I think Raj's view, was that it's probably better to do that circumflex first, and ensure that you have a very good result and that vessel is wide open before you undertake a complex procedure of the CTO.
Yeah, if you have a problem in the LAD and if you make the patient really ischemic by, acutely closing the mid and the distal LAD, which is currently collateralized, and if you have a circ lesion in a dominant vessel like that, you will have, patient's going to get a little bit more sicker than you want to see, So I think that's why I think that, I would have done what Vlad did, that I would have treated the circ and then do the LAD.
So Vlad, if you could stop sharing. Any final comments from all of you about these cases? Or
I think that this was a great session, Dr. Rob. Thank you very much to all three of you. Thanks for hosting this wonderful discussion today. I encourage everyone to keep an eye out for every monthly American Bifurcation Hour. It's been a great resource of explanation on different techniques, very interesting cases and variety of issues are being discussed. It's also been a forum for young practitioners to present their cases, get some experience and be familiar with the bifurcation technique. So I thanks all to the faculty, especially Dr. Rob and Vlad, who's put in a lot of work to get prepared for this session. And I want to wish everyone, we have a big audience today. Happy New Year. We look forward to meeting you every month with American Bifurcation Hour. Also my show, which is called Coffee, Cases and Controversies. We've been focusing on PCI optimization. The next one is on February 6th on Saturday at 10 o'clock in the morning. It occurs usually on Saturday at 10 o'clock in the morning so that all over the world the show can be seen. My guest next Saturday is going to be Dr. Ziad Ali. And we're going to talk about a brand new technology of CoroFlow, and we're going to talk about microvascular dysfunction. And it's going to be very, very interesting topic. Dr. Rob, is the next American Bifurcation Hours date set?
Yeah, so this will be tentatively on Wednesday, February 24th, and Dr. Azim Lateeb and Arasi Moran will present, and they'll choose one of the submitted cases for presentation. But I especially want to thank Kristen for making the effort to submit and show this unique case, which does happen to all of us, and how you approached it was wonderful. And thank you very much for coming up and sharing it with some old guys here who have been doing this for a little while, I guess. So, Vlad, anything from your end?
No, I think that's it's been a great session. Really enjoyed it. Kristen, great case, and all the best to you. I'm sure you'll do well.
Thank you.
Looking forward
to you for joining us. We're coming up to the hour, and thank you for participating in the American Bifurcation Hour. A special thanks to Mia and Elisa for putting up with us and making sure that everything is orchestrated and on time. Thank you very much.
Great. Have a good night, everybody.
Good night. Take care.
Thank you very much. Take care.
Bye-bye.